So maybe I'll get us started while we're waiting for questions to come in. Let me just ask a broad question really to Dr. Rosenberg and Chen, and that is kind of with the data, preliminary data we've seen to date, where do you see R3 fitting into medical practice in the future, potentially?
Yeah, absolutely. I mean, I think Colette really wonderfully demonstrated sort of two particular settings where, I think those of us that have been, using this on the clinical trial, see a potential role. One is patients who are PD-1 naive, who, particularly those that have local regionally recurrent disease, and in whom standard treatment approaches of immunotherapy or immunochemotherapy are suboptimal, and where R3 with SBRT and immunotherapy may be a strategy not only to reduce some of the local regional disease burden, improve function, quality of life, and symptoms related to their recurrent disease, but also enhancing the anti-tumor immunity driven by the PD-1 with some of the immunogenicity data that Sebastian demonstrated on the preclinical side, and then Colette illustrated as well, which what we've observed in the clinic. I think the second space is the 040 and 141 populations of patients that are subsequent line therapy who are IO refractory. We really don't have good treatment in that population. Survival is quite poor after PD-1. We don't have good systemic treatment options, and I'm the medical oncologist, so I can speak to that piece. And there, I think there's another unique opportunity to resensitize tumors to anti-PD-1. We know that treating beyond progression, with PD-1 alone is a suboptimal strategy. And so if there's a way to resensitize tumors to be visible to the immune system through immunogenic manipulation, that would be hopefully greatly advantageous to patients.
Great.
I would absolutely agree with all of what Ari said. And as a radiation oncologist, I'm always very excited when there's a modality that can enhance the effect of radiation therapy. And I think certainly for some of the settings that Ari mentioned, we're very excited about the possibility of combining R3 with radiation to help stimulate perhaps a systemic response in patients with very advanced disease. I think the other setting is just to improve local control. For example, in the NanoRay 312 study, that's for patients who are being treated upfront definitively for head and neck squamous cell cancer who aren't eligible for cisplatin. And that's a situation where R3 is being used as a radio enhancer in lieu of cisplatin to really achieve continued excellent levels of local control or local regional control for those patients. So I think really in that type of setting, improving local control is really important. There may be situations where we might want to try to reduce the dose of radiation to improve tolerance, and that may be a setting where we could use R3. And so I think there are many possibilities. I think, one of the very unique things about this treatment modality is that it's tumor type agnostic, essentially. You can use it wherever it can be introduced and injected intratumorally. It can also be combined with other systemic therapies. It doesn't have to be either or. So really anywhere where we're giving radiation and there can be a tumor that's injected, this can be a modality that we can use. And so that's something that I would be thinking about, not necessarily instead of some of the newer systemic therapies, perhaps in conjunction and in situations where we either want to boost the radiation effect of local regional control or even be able to reduce the dose of radiation.
Great, thank you both. I've seen that a number of people have been in the Q&A section. Does anyone raise their hand so I can have Anne recognize someone?
Yes. Our first question will be from Dylan Drakes of Leerink Partners.
Hey guys, yeah, thanks for taking my questions. This is Dylan on for Jonathan. First question, how much additional effort would be required to coordinate injection with radiation therapy? Is this something that would be feasible across both academic and community-based centers?
I think that's a great question and something that has been really worked out over the first several studies with this, with R3. I would say at academic centers, we found it quite, nothing is easy to set up initially, but I think we have a nice workflow now where we have, injectors for both from ENT for head and neck sites. We have injectors from interventional radiology as well as interventional pulmonology for the lung lesions. And so we've developed a really nice workflow working with those colleagues. I do think it may be a bit more of a challenge in a community setting, but I do know that there are a lot of really large, well-organized community practices that have good relationships that could set this up. One thing that we could think about too is perhaps for many of these things, it's a one-time intratumoral injection. Perhaps the injection could be done at a larger center, and the subsequent treatment, whether radiation or immunotherapy or systemic therapy, can be done locally. I think those would be ways to set that up as well.
Yeah, and I completely agree with Colette. And I'll just add to what she said, which is that, head and neck cancer is unique in that, particularly in that the head and neck surgeon remains very much connected to these patients, even when they develop recurrent metastatic disease. And even though they're not offering surgery for the vast majority of patients with recurrent metastatic disease, they remain intimately involved in that patient's care with scopes, with symptom management, even as patients are getting immunotherapy and other types of systemic therapy or palliative radiation with current standard treatment approaches. And so counterintuitively, reincorporating head and neck surgeons to have a therapeutic role in the recurrent metastatic setting, at our center at least, has been one of the major reasons why the coordination has actually been met with enthusiasm. Head and neck surgeons are excited to, be able to inject this asset to have an active therapeutic role in improving outcomes with some of these approaches. So that's what we found, and I think that's true at other places as well.
And for head and neck cancer, a lot of times these injections don't need to be done in an OR, for example. They can be done, sometimes we just have a procedure room, or even our infusion suite right at the bedside. So it can be pretty straightforward.
Great. I think Michael from Guggenheim was next.
Yeah, hey guys, thanks for taking my questions. I had a question on the study 1100 data from ASCO. Did you break out the data by HPV status for the two arms? Just curious how that looks. And the other question I had was in the PD-1 inhibitor naive cohort, what percentage of those patients had prior chemo, and was that in the metastatic or the local setting?
So for the HPV question, that wasn't presented in the ASCO poster from this year, but last year we did break things down, at least for the patients to date there. In terms of HPV status there, the disease control rate was pretty similar between HPV positive and negative. It was about 70% for HPV positive, about 67% for HPV negative. And the objective response rate was perhaps a little bit higher with the HPV positive patients, 29% versus 17% for HPV negative. Again, that was based on data from last year. So certainly that analysis will be updated as we have more patients. And I think your other question was for the resistant group. I think you were asking, the naive group. I think you were asking about prior systemic therapy.
Correct.
Those patients, I would say, some have had chemotherapy, but fewer of those patients were treated with as many lines prior to enrolling on the 1100 study. So in many cases, those patients saw chemotherapy as part of their initial chemoradiation, as opposed to subsequent chemo for recurrent metastatic disease.
Yeah. Can I just ask a quick follow-up? I think you said the other place where R3 could be interesting would be in the patients that are ineligible for systemic therapy up front, so the chemotherapy ineligible patients. And we've heard different estimates there, what percentage of patients would fall into that category. What has your experience been there?
Yeah, I
Dr.
mean,
Shen.
the data suggests that about a third of head and neck cancer patients are ineligible for cisplatin. So it's quite a substantial proportion. There's some disagreement within the field of what constitutes ineligibility for cisplatin, and there's certainly patients that are on the border that there's some heterogeneity in the approach. But it's a substantial proportion of patients. We know that head and neck cancer patients is largely diagnosed in increases in incidence with older age. So over 70 years old is quite a common area of cancer patients. With HPV positive disease, we've actually seen a big uptick in elderly patients in their 80s and even 90s with HPV positive. Historically, we used to think about those largely in younger patients, but there's actually data suggesting that that's increasing in incidence in older patients now as sort of time passes as well. So it's a substantial proportion, either because of age or comorbidities or frailty that may make cisplatin a suboptimal treatment approach. As you know, CIS-RT is a tough regimen. We cause a lot of substantial toxicities for patients. It's not, that's something that we sort of see in the clinic.
Great, thank you.
Thanks. I think Lucy from Jefferies was next.
Hi there, thank you for taking my questions. So I guess you may not be able to answer this, but I would be interested to get your thoughts on how you would think about designing the next trial or trials for the head and neck cancer setting in combination with immunotherapy. And I guess, would you think it would be best to split that into two separate trials in terms of prior resistance or naivety, and also potentially stratifying by HPV status, just given some of the developments we're seeing in terms of HPV-directed cancer vaccines, and just better delineating where this might best sit? Thank you.
I can start, and Ari can add, but I do think we do need a randomized trial to really demonstrate this combination versus standard of care. And I would agree with you that probably there need to be two designs for the immune checkpoint inhibitor naive and the refractory. They're just different patient populations. So for naive, probably randomized to pembrolizumab alone. There did not seem to be any benefit to just adding SBRT in that memorial study. So I think probably a randomization with pembrolizumab alone. And then for the prior resistance to immune checkpoint inhibitor, probably perhaps a randomization with a physician's choice, depending on perhaps HPV status. And I think maybe Ari can add to that as well.
Yeah, no, I completely agree with Colette. I mean, I think a randomized study is needed, and I think that's exactly right. The one thing I'll just add is that, right, this is not a systemic therapy in the classical sense, and so the design can be adapted if the systemic therapy standard of care changes. I know you highlighted some of the other assets that are being developed in the head and neck cancer space. But I think R3 is unique because it's an intratumoral injection, it's immune enhancing, but it's not a systemic therapy. And so a design could be easily adapted, with what an appropriate control arm would be.
Great. Thank you.
Thank you.
Thanks. I think Ramakant from Wainwright next.
Thank you. Thanks for taking my questions. There are two of them. The first one being talking about the patient that Dr. Rosenberg put up from study 1100, where you were talking about the patient being a PD-1 negative, having PD-1 negative status, and also being difficult surgical resection. how often do you see such patients? That's question number one. And question number two is based on the data that we have seen from Keynote 040 or Checkmate 141, where we see mid-teen response rates and 7 to 8 months of OS. And I'm learning what we have learned from R3. Is there any meaning in reversing the sequence, in the sense trying to initiate therapy with R3 and then going to PD-1 therapy in some of these patients?
Yeah, so to answer your first question, I would say having some component of local regionally recurrent disease is, I would say, actually more common than not when we see patients with recurrent disease. I think I showed some of a slide I usually think about, sort of a third of patients developing local regionally recurrent disease, a third having distant only disease, and that other third having some combination. And I would say that's pretty consistent with what I see in clinical practice. Of course, the additional component is that most of the time in the clinic, the recurrence, the component of the disease that's having most of the impact on in terms of pain, quality of life, and function is the recurrent disease, right? This is largely previously irradiated disease setting. This is a space with high value real estate, eating, speaking, swallowing, a lot of nerves, a lot of complex structures. This is why head and neck cancer is a very challenging disease to treat, even in the upfront setting. So I think that's also important to highlight for your first question. Your second question, maybe I didn't totally hear, but you're asking about the sequencing of R3 and immunotherapy. Can you clarify a little more?
Yeah, so trying to sensitize the tumor more. So does it make sense to first do R3 with SBRT and then treat with any of the anti-PD-1 therapies, so that you're sensitizing the tumor ahead of giving anti-PD-1?
Yeah, so that's actually how the trial is designed currently, for exactly the rationale that you provided. That's exactly right, which is that the idea is to sensitize first and then do PD-1. We actually start the PD-1 the day after, the business day after the SBRT is done. And we coordinate that closely with Colette or our radiation oncologists in terms of that timing to try to start the PD-1 as soon as that radio enhancement occurs. So, and that immunogenic priming occurs. So I think that's exactly the rationale. And I think the data that Colette showed, in terms of IO naive versus IO refractory is also very important to illustrate that as well, right? In the IO naive population, you see incredible activity with that priming before patients have received any anti-PD-1. I think that's important to highlight as well.
Man, I think that may be what you were trying to get at with the question is, should we try to move this ahead and not allow them to develop that resistance to anti-PD-1 therapy, but start it early? And I think that makes sense, especially for patients who have maybe not widely metastatic disease, but more limited oligometastatic disease or local regionally recurrent, where we can try to really get as much of the tumor control with both local control and immune therapy earlier, as opposed to waiting until they've had multiple lines of treatment. It just becomes harder and harder once they become more heavily pretreated. So I think that's a good point, and that's one of the goals.
Great, thank you. We have a question from Dylan Leerink.
Yeah, thanks, guys. Just one more question from me. Would you be able to comment on how common the practice of re-radiation is in RM head and neck cancer? And do you envision the data from Study 1100 will increase the adoption of this practice?
It really varies, I think it varies institution to institution. We tend to do a lot of reirradiation. I know there are places that tend to be less comfortable. I would say most larger academic centers are probably quite comfortable with reirradiation, and most places are doing it fairly frequently, at least at the larger centers. In terms of reirradiation, it's all over the place. We do a fair amount of SBRT reirradiation, both because, patients have already been through a round of 6 or 7 weeks of radiation and may not want to do that again, or be able to. Oftentimes the recurrent disease may be a little, more focused than the initial extent of disease. But on the flip side, the other way that we sometimes do reirradiation is with a really, long course of twice a day radiation. And so I think if, there's a pretty big space to work with in terms of achieving better disease outcomes in that setting. I do think ways to enhance reirradiation with some of these modalities, combination with systemic therapy, checkpoint inhibitor therapy, R3 can really enhance the outcomes with it while limiting side effects. Because like Ari mentioned, the side effects of one round of treatment are already really hard. You put in another round of treatment, there are risks. We are finding more comfort with avoiding some of the more serious side effects with reirradiation, like carotid blowout, for example. There are ways that we've been developing, dose constraints around those vessels or ways to plan around it. So we're becoming quite comfortable with reirradiation, especially with SBRT.
Yeah, I completely agree. And the other thing I'll just highlight is that I think the thinking around reirradiation has shifted in the era of immunotherapy, because we see, as you saw from Colette's data that she showed and my data as well, which is that with PD-1, we do see a subset of patients who have deep, durable responses in the immunotherapy era. And so reirradiation, rather than being a be-all, end-all, last-ditch effort, for lack of a better term, I think now has more of a role of how do we incorporate it in a way to improve symptom burden and overall tumor burden for these patients that have quite extensive recurrent disease. And furthermore, how do we use that to leverage all of the progress we've made with anti-PD-1 based therapy and in combination, and hope to continue to improve with sort of the evolving landscape. So I do agree with Colette completely that the strategy of how best to incorporate reirradiation has shifted and requires very close collaboration between medical oncologists, radiation oncologists, and surgeons.
All right, thank you. Let's see. All right, so I have a few questions of our own. Dr. Rosenberg, you touched on, to the question about the a randomized study, the potential value of an adaptive because of the ability with R3 to potentially be added to some of these other pipeline agents that are in development. Could you and also Dr. Shen kind of elaborate on that idea of R3 being used in combination above and beyond kind of current checkpoint inhibitors?
Yeah, I mean, I think, what's unique about R3 is that it's not a systemic therapy that has a lot of overlapping toxicities with other agents that are being developed. And we have emerging safety data of R3 with SBRT, not only with immunotherapy, but other assets as well. And we should continue to hopefully see more of that. I think that the enhancement or the priming of anti-tumor immunity is beneficial not only across anti-PD-1, but other potential IO assets beyond anti-PD-1 or in combination with PD-1, which I think situates it uniquely in terms of opportunities for incorporation and treatment paradigms for recurrent metastatic head and neck cancer.
Yeah, I'll just add to that. I would agree with, combinations with other immunotherapies, but there have been some early safety data with other chemotherapy agents, cisplatin, 5-FU, capecitabine. So I think in those situations, we could imagine using R3 to enhance the response, for example, for unresectable tumors, locally advanced that may not be eligible for surgery. We could think about it for perhaps, HPV negative head and neck patients where we know we need to do better and we can't really de-escalate like we can with the HPV positive patients. Can we do combination of R3 with radiation and cisplatin for those patients or other systemic therapies that are being developed? So like Ari said, it's not, either or with some of the newer agents. We can use them in combination pretty much anywhere where we're going to be giving radiation.
And a follow-up question to the comment about potential patients who are not eligible for resection. What's the status right now of some of the checkpoint inhibitors in terms of neoadjuvant head and neck? I mean, it already has approval in non-small cell and some other settings.
Yeah, that's a good question. Locally recurrent disease are some of the most contentious discussions in our tumor board. And that's because it is a challenging disease to treat and one that requires a lot of input, multimodality input, multidisciplinary input from med-onc, rad-onc surgery, but also from the patient, and also from other specialists, right? I mean, speech pathology and et cetera, et cetera. So I'll start with that. I think for, small recurrences that are easily surgically salvageable with, for example, a neck dissection, for example, I would say that still remains the standard of care curative intent treatment approach for those diseases. And we do see a subset of those, although many of the recurrences that we see are much more extensive and not amenable to an easy, a feasible surgical salvage with good functional outcomes and things like that. And then that's where we think about going down these other potential pathways. So, I would say there are clinical trials that are trying to look at neoadjuvant immunotherapy in the context of easily surgically resectable disease, and those trials are ongoing. I think that's a different patient population, different setting than much of what we're talking about, which is really recurrent disease that's not amenable to a true curative intent surgical salvage that's going to give patients, cure with long-term function. I don't know, Colette, how are your tumor boards for the recurrent cases?
Very similar to what you described. If it's resectable anyway, the surgeons are going to want to take it out. So we're talking about different populations. I agree.
Great. I want to also maybe bring in Sebastian too to this next question. So we touched on combinations, but given the biology, some of the data that's been generated at least preclinically and correlative data, are there particular types of agents that one would see as making a lot of sense? And I'm specifically thinking of IO type agents, right? So, some people, there are a fair amount of activity in head and neck. A lot of them are IO of many different flavors. Rather than thinking of those as potentially competitive, it's quite conceivable given how R3 works to think of them as being combinable. So.
So as you have seen on the slide that I presented, we have combined different types of checkpoint inhibitors. Like for example, the anti-CTLA-4 and anti-PD-1, which is a very standard combination of CPIs. But we can also imagine to combine anti-PD-1, which work very well with a different type of CPI, like for example, with antibody targeting the macrophages, because we know that macrophages have a very important impact on the efficacy of the treatment. They are most of the time pro-tumoral immune cells. So if we are able to maybe target both population, I mean the CD8 T cells, and eventually if we are able to combine this treatment with NBTXR3 radiotherapy and something that maybe can block the activity of these macrophages, we can maybe have a kind of synergy between all these checkpoint inhibitors to have a better immune response.
Right. So, of course, with the recognition that both you, Ari, and Colette are focused in head and neck, but in thinking about, kind of the potential broader utility of R3, any comments you want to make there in terms of additional tumor types? Clearly potential for other settings within head and neck cancer.
Yeah, I mean, I'll just briefly touch on, the 1100 study has another cohort of patients who aren't head and neck cancer patients. And we've been seeing some really promising activity. Of course, we don't really have very complete data for that cohort 3 yet. But for example, I've had quite a few patients with melanoma who have been treated on study who have done quite well. And I think that group makes sense because of, the use of immune checkpoint inhibitor therapy for those patients, but perhaps, there may be some limited local regional disease that's being a little stubborn, and we can make use of R3 and SBRT to help jumpstart that response a little bit more again. So I think that's a very promising patient population for this. I work with quite a few lung cancer specialists who are very excited about R3, both in kind of earlier stage as well as more advanced stage. The Pacific study showed promising activity with immunotherapy in the, locally advanced setting for non-small cell lung cancer. Could this be used for earlier stage disease, perhaps for larger tumors that may be unresectable, but need a little bit more of that response to radiation, and could that be combined with immunotherapy? So there are different ways that I think those are just a couple of the settings, in addition to soft tissue sarcoma, which has already been studied with R3, but I think that's another area that would be really nice to continue to look at.
Great, thank you.
Yeah, and I would just add to that, I completely agree. And one of the nice things about the nature of the injection is that it engages specialists beyond head and neck cancer. So our interventional pulmonologist has injected a lot of R3. Our interventional radiologists for liver metastases, for example, has been very engaged, and that's generated enthusiasm across the multidisciplinary subtypes. Even if they're not within our head and neck cancer tumor board, but in parallel other disease specialized tumor boards. And we do get referrals for metastatic lung cancer patients, melanoma, and such for consideration for R3. And so I think awareness of this beyond head and neck is taking hold.